RSV Academy. Shredding papers. Bivalent RSV Prefusion F protein vaccine in older adults.
So the article that I'd like to discuss today is the article by Walsh et al. That was published in the New England Journal of April of this year, which describes the safety and efficacy of the bivalent RSV Prefusion F vaccine in older adults. And this was the pivotal efficacy trial for the RSV vaccine for adults. So the vaccine that was studied is bivalent and stabilized in the prefusion state. And the sequence was based on contemporary RSV A and B strains. And we now know that the neutralizing titers stimulated by Prefusion F is very robust for both RSV A and RSV B in phase 1-2 studies. So the program that Pfizer has is targeted for maternal immunization in older adults over age 60. And this trial focuses on the older adults. And it's for the prevention of lower respiratory tract illness. So it was a big study, 240 study sites in 7 different countries. The targeted enrollment was up to 40,000 people. And it was randomized 1-to-1 to receive vaccine versus placebo, and was stratified by age group, ages 60 to 69, 70 to 79, and over age 80. The key exclusionary criteria were that you could not be immunocompromised and that chronic conditions were perfectly fine, but you had to be medically stable. So the first person was enrolled on August 31st, 2021 in the Northern Hemisphere and November 23rd, 2021 in the Southern Hemisphere. So this is just a schedule of the study, and there was the primary efficacy group was the whole group, but there was subgroups looking at reactogenicity, and those people filled out diary cards electronically regarding any systemic or local side effects. And there was also an immunogenicity subset. And there was a pre-planned efficacy analysis once a certain number of cases of RSV disease with either greater than 2 or greater than 3 symptoms were accrued. Listed below are the definitions for RSV ARI, so more than one of any of these symptoms. And then LRTI, lower respiratory tract symptoms, are listed here: cough, wheezing, sputum production, shortness of breath, or tachypnea. And it had to be within 7 days of the respiratory tract illness. And to be included in the primary outcome, they had to be PCR positive by a validated RT-PCR. So these are the main demographic and baseline characteristics. Overall, there were a little over 17,000 people in the vaccine group, 17,000 in the placebo group. And they were, as you can see here, well distributed amongst the racial and ethnic groups. And that there was the greatest number of people between ages 60 and 69, roughly 62% of the populations, with about 32% ages 70 to 79, but only greater than 80, only about 5.6% in each group. So the mean age of the study population was 68.3. And there was an attempt to enroll people with underlying high-risk conditions, and so 15% in each group had some kind of chronic cardiopulmonary disease, and they're listed here. But the overall rates were relatively low. 18% had diabetes, and around 12 to 13% had any kind of heart disease. And what is notable is that roughly half the population did not have a high-risk condition. So these are the primary outcome results, and this is RSV lower respiratory tract illness with greater than 2 signs, so not quite as severe as 3 signs or symptoms. And these are reverse cumulative plots with the placebo shown in blue and the vaccine group shown in the sort of yellow color over time. And the efficacy was 66.7 with a confidence interval from 28.8 to 85.8. And so it clearly met the predefined success criteria. But I will point out, if you look down below, that the overall rates of infection were relatively low, 33 in the placebo group and 11 in the vaccine group. When we look specifically at those with greater than 3 signs or symptoms, again, that the number of cases was relatively low, 14 versus 2, but the efficacy was 85.7 with a confidence interval of 32 to 98.7. So again, well within the criteria for success, but there were limited numbers of cases. And then lastly, this is really for any acute respiratory illness. So this is, basically a cold, but also incorporating the other categories. So there were 58 in the placebo group, 22 in the vaccine group for an efficacy of 62.1. And, I found this actually somewhat remarkable that you can prevent an upper respiratory tract infection with a systemic vaccine. When they tried to look at the different risk groups by 2 symptoms or 3 symptoms, you can see that they did not have enough numbers to really nail down efficacy. The confidence intervals do cross 1, but all of the point estimates are in the direction of vaccine efficacy. It was well tolerated, and these are the local reactions, with the primary one being pain at the injection site, and then the systemic reactions down below, where you can see that it's really mostly fatigue, headache, and muscle pain. There were very few severe reactions, so it was really quite well tolerated. Of note, there was 1 case of Guillain-Barré and 1 case of a Guillain-Barré variant called Miller-Fisher, and they did both occur in the vaccine groups. Both people recovered, and there was also a numerical imbalance in cases of atrial fibrillation, and that did not reach statistical significance. So, in interpreting this study, my conclusions would be that the RSV pre-F vaccine was highly effective to prevent RSV-related lower respiratory tract infection. The vaccine was also effective to prevent RSV acute respiratory infection. The vaccine was well tolerated. It is unclear at this point if the neuroinflammatory events are a real but rare side effect or within the realm of chance, since Guillain-Barré, the incidence increases with increasing age. At the age group affected or enrolled in the trial, there's probably about 3 per 100,000 at baseline, so 1 in 33,000. The trials were not really adequately powered to assess efficacy in the highest risk patients. They were a relatively healthy population, which is really quite common in these large pivotal efficacy trials. It's hard to get the really sick people to come in and volunteer in the clinic. So efficacy to prevent hospitalization and deaths could not be assessed because the number of hospitalizations were really very low. I skipped over the fact that the trials were very much impacted by the COVID pandemic, and such that there were much lower numbers of RSV cases than would have been predicted. And so the fact that there was a relatively healthy population and that there were relatively low numbers because of the pandemic, hospitalization could not be predicted. In my mind, if you can prevent lower respiratory tract disease I think it's highly likely that it would prevent hospitalizations.